Hi, my name is Michelle, and I'm with Optometry Times, and I'm here with Ben today to talk about his article, When Enough is Too Much. You want to introduce yourself, Ben?
Sure. My name is Ben Casella, and I'm an optometrist with Casella Eye Center in Augusta, Georgia.
Okay. All right. Well, first of all, tell me a little bit about your article.
Sure. The article describes one of my favorite glaucoma patients. She's a 66-year-old Caucasian female. I inherited her a few years ago. She moved down here from the Midwest, and she was found to have unilateral open-angle glaucoma with visual field loss. And her eye care professional in the Midwest had done a laser procedure, and around the same time had given her three different medications: a prostaglandin, a combination drop, and a alpha agonist to treat her eye pressure. She presented to me with eye pressures of 10 in the affected eye and 12 in the non-affected eye, and we went along for several months and to several years, and I was gradually able to get her off of some of these medications while keeping a close eye on her eye pressure. And as it turns out, she was being a bit overtreated.
Okay. How do you decide when to be more or less aggressive in a treatment?
That's the big question with glaucoma today. When do you pull the trigger and initiate treatment? Is what you're seeing glaucoma at all? Glaucoma, by definition, is a progressive optic neuropathy, which means if it's not progressing, then it's probably not glaucoma. And then there's going to be those people who are going to progress despite being on multiple drops and even having multiple laser procedures. But the key, in my opinion, is to get as much diagnostic value, both structurally with things like OCT as well as functionally with visual field studies early on, so that you can get a feel for how quickly, if at all, is this patient going to progress.
Okay. Tell me a little bit about your treatment of this patient that you discussed in your article.
Sure. Well, when she saw me, she was on prostaglandin at nighttime, and she was on a combination drop twice daily, and she was on another additive drop 3 times daily. She also wears multifocal contacts during the day, and she really didn't like having to take her contact out in the middle of the day to put that noon-ish drop in. When I saw her, I did detect that her diagnosis was indeed correct. She had unilateral open-angle glaucoma, and she had field loss. She was not, however, about to cup out. She was not advanced. She was not at risk of losing imminent vision, she was not at imminent risk of losing vision in that eye. So I told her, okay, stop the 3-time-a-day drop, come back in several weeks, and we'll re-evaluate things. And so I did, and her pressure didn't really go up hardly at all. So we plugged along like that for a year or so, and one other thing that I had done is I had told her to move her combination drop, which was COSOPT. I had her move that from morning and night to morning and late afternoon, hoping, maybe because your beta receptors go to sleep when you go to sleep, hopefully I could get a little more bang for my buck and get maybe another point or two off of her IOP, maybe, and as well not initiate beta blockade when she's asleep, because there's decent evidence that shows that can actually be disruptive to optic nerve perfusion. So we plugged along like that for a little while, and then I was eventually able to do her one better. I had her drop her COSOPT down to just in the morning. So at this point, she's on COSOPT in the morning, and she's on a prostaglandin at night. All the while checking her IOPs at different points in the day, every 2 to 3 months, and as well keeping a close eye on OCTs and visual field studies, making sure that I'm doing no harm. That being said, a year or so later, I was able to get her off of the COSOPT altogether, and to this day, she is really enjoying just being on a prostaglandin at night. I will continue to evaluate her IOP periodically at different points throughout the day, and I will continue to be diligent with OCTs and visual fields. And if I can document progression, I'll probably put her back on the combo drop in the morning, and then we'll build up in a stepwise fashion. However, one thing that I didn't realize was what a quality of life improvement I had been able to give her, because now she can just keep her drops on the bathroom sink or the bedside table. But one thing that I mentioned at the onset, she had an ALT procedure done. She had argon laser trabeculoplasty done. At this point, that's been over 7 years ago now. So she's probably not getting a whole lot of bang for her buck with that anymore. So what that tells me is that I'm achieving a very nice IOP reduction with just a prostaglandin, which I should mention, I'm getting an almost 50% drop from her maximum IOP before her eye care professional in the Midwest initiated therapy.
Okay, great. How do you decide, especially with the patient coming to you for the first time and having no history of them, how do you decide when to stay on their same regimen or to make a change?
Sure. Well, first thing, of course, do no harm. You, of course, want to obtain medical records, which I was lucky to be able to do in her case. It doesn't always work out that way. You can have patients sign releases until the cows come home, but there are some records that you just won't get. So in that type of a situation, I sort of tried to whittle it down to its very simplest form and say, okay, she has glaucoma. She's being treated with multiple drops. She's not about to cup out. If I try something for a few weeks here and there, it's not going to make her just all of a sudden lose her visual function in that eye. So sometimes when you absolutely cannot get medical records on a patient, which I see patients through a vocational rehabilitation service here in Augusta, and a lot of those patients were treated throughout various prison systems, and it's really difficult to obtain those records just because of clerical issues. But sometimes you just kind of have to say, okay, I'm going to whittle this down to its very simplest form and almost start over. And there are patients that I see who have glaucoma that if I just can't get any information about what their eye pressure was before they came to me, I might say, okay, here's the deal. Stop your drops. Come back and see me in a month. Not a lot of harm is going to be done in a month, but it gives me a good, a month is a pretty good washout period for a lot of glaucoma medications, and that will sort of allow me to start over and just see, okay, what is your pressure going up to? And then once I establish a maximum pressure, what I'll do is I'll go back to the major peer review studies and I'll come up with a target pressure. Sometimes after I've gotten a couple of visual fields and a couple of OCTs under my belt.
Okay. What would you say you have learned from this experience of removing some medications, and how might this affect your treatment in the future with other patients?
Sure. I've learned that, first of all, glaucoma is the silent blinder. There are a few million Americans walking around with it. There's probably many, many more that are undiagnosed at this time, and we have to be highly sensitive. However, we also have to be highly specific in our glaucoma care, and it really boils down to individual patient factors. If this patient was 26, I may not have done that, because if she's 26, then she has presumably 6 or so decades left of nice, sharp vision, and I don't want to do anything to disrupt that. If she was 126, I may have taken her off of everything altogether and said, let's just see what your eye pressure does now. She was 66. She has presumably a couple of decades of good vision left. But you really have to treat each patient individually. And if you stick to the studies, stick to the peer review literature, then it affords you the opportunity to be highly specific in these patients as well. I think it's important to note that glaucoma is also And I know that I learned this before, but I can never be reminded enough. Glaucoma is typically very slow to progress. And there are a lot of lurking variables. There are systemic considerations. There are considerations with your blood pressure, your blood sugar, your blood chemistry. There are individual patient factors such as cost. Just because Zalatan is generic doesn't always mean that it's cheap. It hasn't made its way onto the target $4 plans yet. But there is a lot to consider with a glaucoma patient, especially when you're thinking of when can I pull back a little bit, or when do I need to go ahead and pull the trigger. But you've got time to figure that out. And there's going to be glaucoma patients that you don't even treat, I promise you. But you've got time to sort through that. And glaucoma is a heck of a, it's a beast of a disease. It really is. It's the silent blinder. It's complex. It's multifactorial. It's complicated. But if you just slow down and go in a stepwise approach and be logical and do a lot of diligence on the front side of things with collecting structural and functional information on the patient before you decide how aggressive you need to be, you will find that it's a lot easier to deal with when you keep that logic